Well, what about blood pressure? Because if we're referring to a vasodilation, vasoconstriction, one of the ways in which we can move blood around the periphery, both in terms of on the arterial side, but also in terms of venous return, is through blood pressure responses. Particularly this idea of where we're moving down pressure gradients. We've got high pressure at the heart, but as we move away from the heart, the pressure starts to fall. And of course, on the venous side, one of the only ways that we can get the deoxygenated blood back through the circulation is by using blood pressure gradients. Well, the first thing is this: we've got arterial blood pressure, and arterial blood pressure increases with exercise intensity. But if we take arterial blood pressure, we have to recognise that arterial blood pressure is a function of systolic and diastolic pressures. Well, the systolic pressure increases linearly with increasing workloads. Diastolic pressure, on the other hand, actually remains equal to the resting values or decreases slightly with increasing workloads in healthy individuals. If we take systolic blood pressure and we look at it maximally, we know that's linked to age, it's linked to exercise intensity, it's also linked to left ventricular function. Now this is really important. Systolic and diastolic volumes are what we mentioned in relation to stroke volume. So the blood pressure that we record using a sphygmometer, for example using the cuff, whether we use it automated or we use the stethoscope approach, that systolic blood pressure is proportional to the systolic volume in the heart. So you can suddenly understand why systolic pressure rises with exercise intensity, because the volume that's being ejected, that is systole, in the heart also increases in response to exercise intensity. But remember, one of the things that we mentioned was that diastolic volume actually remains constant during exercise, and that's not surprising because we also see a levelling in diastolic blood pressure. It remains equal, and that's because what we don't want is we don't want that dramatic. We don't want diastolic pressure to go up, because diastolic pressure going up would probably suggest that we've got an increase in diastolic volume. And actually, ideally, we want diastolic volume to remain either constant because we're getting free ejection, or go down because we're just pushing beyond that backflow of blood into the ventricle. So here we can see some data in a hypertensive individual, somebody with high blood pressure in the right panel, and somebody who's normotensive, that's normal blood pressure, in the left panel. And what you can see, constant load exercise, so we're not changing the workload, but you can see three components: mean arterial pressure, which is the function of the systolic and the diastolic pressures, and you can see the systolic and the diastolic pressures themselves. And notice the quite considerable differences between the hypertensive and the normotensive individual. That the mean arterial pressure in the hypertensive individual is around about 90 millimeters of mercury, but actually in the normotensive, it's about 100 in the hypertensive and it's about 90 in the normotensive. So they've got a lower blood pressure compared to the normotensive individual. If we look at systolic blood pressure, remember systolic blood pressure is related to systolic volume at the heart, and we look at our hypertensive individual, we're looking at around about 125, and if we look at our normotensive individual, again we're looking at about 125. If we look at distally though, distally is quite interesting. In our normotensive individual, it's about 75 for dystolic, so that's giving a good indication of dystolic volume, and it's slightly higher in our hypertensive individual. So under these conditions, there's very little difference in the blood pressure responses. Slightly elevated mean arterial pressure, mean, which is the function of the systolic and the diastolic, in the hypertensive individual compared to the normotensive individual, but a fairly constant pressure, because the exercise intensity, although this is under recovery conditions, the exercise intensity is remaining constant. Were the exercise intensity to go up, we would see systolic blood pressure rising, diastolic blood pressure remaining constant, and as a result only a gradual increase in the mean arterial pressure in both groups.